yesterday that last year they did 2,500 radical prostatectomies in Hamburg, which is an immense number, and I'm looking forward to your talk. Thank you.
Thank you very much. First of all, thank you for the kind invitation. I will talk about salvage options after radical treatment of prostate cancer. I have no disclosures. I will go over the impact of biochemical recurrence on oncological outcomes first, because that also is important in deciding if all these patients do need really to have salvage options. Then I will talk about salvage lymph node dissection, which is one of the options for lymph node recurrence. We will shortly go over salvage radiation treatment in patients with persistent PSA. And at last, I will talk about salvage radical prostatectomy, one local treatment option after radiation failure. So we looked at more than 14,500 patients from our department who underwent radical prostatectomy between 1992 and 2012. And when excluding patients with neoadjuvant or adjuvant therapy after a median follow-up of 51 months, biochemical recurrence occurred in about 20% of the patients, and this depended, of course, on the risk group of these patients. Just recently, we, within the EAU guideline panel of prostate cancer, we conducted a systematic review on the prognostic value of biochemical recurrence. And this showed similar results. Approximately 30% of patients with BCR after primary surgery develop clinical recurrence, with only about 16% dying from their disease. So depending on these results, we propose to stratify patients into so-called EAU low-risk BCR, which is defined as a PSA doubling time of more than 1 year, and a pathological grade group of less than 4, so less than Gleason 7 or less, or a EAU high-risk group, which was defined as Gleason 8 to 10, and PSA doubling time of less than 1, since all patients not all patients with biochemical recurrence will have similar outcomes. And this classification will appear in the next guidelines probably. So to validate this, we used our patient cohort from the Martini Clinic. This is not published yet. We externally validated this risk classification for BCR, and we included 510 patients which were considered as EAU low-risk BCR, and 530 patients who met the EAU high-risk BCR criteria. And we nicely see here that this classification does stratify these patients into the two risk groups. What is even more interesting is when we only look at the EAU high-risk BCR patients, meaning the ones with PSA doubling time less than 1 year and a Gleason 8 to 10 in the pathology, we see that the patients who did not receive salvage radiation treatment do much worse than the ones who do receive early or late salvage radiation, which shows that even these patients with persistent with BCR, with the high-risk BCR, do profit from the salvage radiation. But in the EAU low-risk BCR group, where the question is if patients should even receive a salvage treatment, the patients did do the same, either if they got salvage radiation or not. So this EAU BCR risk grouping can be of help in deciding if all patients with BCR need treatment. Actually, I didn't move forward because this is not connected. So this was what I was talking about. When patients with EAU high-risk BCR receive salvage radiation, there is a profit. When they are low risk, they don't profit. Another conclusion from this review was that once you have biochemical recurrence, people use PET CT earlier and earlier, and this had led to a shift towards early detection of low-volume metastatic prostate cancer, isolated nodal recurrences, and in turn, this has contributed to an interest in metastasis-directed therapies such as salvage lymph node dissection. So I will move over to this topic. The success of salvage lymph node dissection also very much depends on the accuracy of PET imaging prior to salvage lymph node dissection. And while in the earlier years, Choline PET CT has been used in this setting, we saw in the different studies that while the specificity could be high up to 90%, the sensitivity was quite low with 64 to 68% for Choline PET. So authors concluded that a positive PET CT correctly predicts the presence of lymph node metastasis in the majority of patients with BCR after radical prostatectomy, but it might underestimate the extent of nodal recurrence. So nowadays, PSMA PET is state-of-the-art and is used, and here you clearly see the difference. With Choline PET, detection rates for patients with PSA recurrence of 1 to 2 was about 43%, while when using PSMA PET CT and having a patient with a PSA 1 to 2, about 93% of detection rates are achieved. So this is a great difference. When we looked at the PSMA, at the patients with salvage lymphadenectomy in our department who all had a PSMA PET CT, 23 patients with nodal recurrence, we found in the field-based analysis that the sensitivity was higher for PSMA PET with 76%, but still it was not perfect. So even in patients who have PSMA PET scan, the extended salvage nodal dissection is needed in these patients to pick up all of the nodal lesions. There has been recently a systematic review on this topic, also from the Young Academic Urology Prostate Cancer Working Group of the EAU. And overall, we included 27 salvage lymph node dissection series in this systematic review. The 2-year biochemical progression-free survival rates ranged from 23 to 64%. There was a variety of outcomes in all of these studies, and reasons were that the studies were of retrospective design, single-center studies. There was heterogeneity between the series in terms of adjuvant treatment endpoints, definitions of progression, and study population. Also, the studies had a short follow-up. Here's a summary of salvage lymphadenectomy series older ones, which were based on Choline PET scanning. And what this shows that, as I said, the outcomes are very heterogeneous. Complete biochemical response, which is defined as the PSA of 0.2 of less than 0.2 after salvage lymph node dissection, ranges between 13 and 79%, so a very wide range. But what all of these studies show is that biochemical recurrence after salvage lymph node dissection occurs in almost all the patients. These are some of the newer series which all use the PSMA PET. And what this shows is that the PSA response rates are better than in the Choline PET setting. They range from 44 to about 65%. And one of the studies with the highest number of patients is the multicentric study from Fossati and colleagues with 654 patients who underwent salvage lymph node dissection. And these authors defined the optimal candidates for salvage lymph node dissection and found that it should be a patient with less than Gleason grade group 5. There should be a longer time from radical prostatectomy to BCR. And ideally, there should be less than 3 nodal lesions on PET scan. This is another multicentric study. We were part of it. It looked at standard of care versus metastasis-directed therapy for PET-detected nodal oligorecurrent prostate cancer. And the standard cohort received immediate, or standard of care cohort received immediate or delayed androgen deprivation. The metastasis-directed therapy cohort was a combination of patients who received salvage lymph node dissection, but also patients who received stereotactic body radiotherapy at PSA progression. These were different cohorts, so they had to be propensity score matched, and after propensity score matching, clearly it was visible that patients with metastasis-directed therapy, either through salvage lymph node dissection or through radiotherapy, did do much better with regards to cancer-specific survival than the other group. In our hospital, since about 1 year, we use a so-called PSMA radio-guided approach for doing salvage lymphadenectomies. All are done as an open salvage lymph node dissection. And for this aim, we use we do preoperative injection of technetium-labeled PSMA ligands, and intraoperatively, these are detected by a gamma probe, as you see in this picture. And also, there's acoustic and visual feedback. We just recently published the comparison of the two groups. So we looked at our earlier salvage lymph node dissection, which were done with a conventional approach, 29 patients, where we did not use the PSMA radio guidance, and we compared it to 13 patients who did receive PSMA radio-guided surgery. This is how it looks intraoperatively, again using the gamma probe, and also you hear a beeping sound and see visually if you detect the PSMA ligands. And what we found is that for the short-term outcome, the mean PSA after 6 weeks was significantly lower in the group who received radio-guided surgery versus the group who received the conventional surgery without the help of the probe. Also, we saw that there's a much higher PSA decline in the PSMA radio-guided surgery group when compared to the conventional surgery group. Interestingly, in our cohort of the conventional surgery groups, 9 patients, which means about 30% of the patients, had a final pathology without metastasis, whereas in the radio-guided surgery, the removal of all visible lesions was pathologically confirmed. I said that we only do the open salvage lymph node dissection right now with this probe because the probe is only commercially available for the open approach, but actually there's a Dutch group which just works on a so-called drop-in gamma probe, which you can use for the robot, and we had the opportunity to try this last year for the first time in the Martini clinic. It worked similar to the open approach, and I think the probe will be commercially available soon. So in conclusion, for the salvage lymph node dissection, retrospective data suggests that surgery may represent an important therapeutic modality in the management of nodal recurrence. The identification of patients who will benefit from surgical treatment depends on imaging, which at the moment still may underestimate the load of metastases. PSMA radio-guided surgery may improve oncological outcome after salvage lymph node dissection, but prospective randomized studies comparing salvage lymph node dissection with the current standard of care and other interventional strategies are missing and are needed to provide more evidence. Now moving over to salvage radiation treatment in patients with persistent PSA. Persistent PSA is a problem for all of us. We looked at our patient cohort from 92 to 2016 and saw that almost 9% of the patients had persistent PSA, which is defined as a PSA value, which we defined as a PSA value of 0.1 or more at 6 weeks, and this is the definition used in most of the studies which are available. And clearly, as seen here, at 15 years after radical prostatectomy, oncological outcome is much worse in the patients with persistent PSA when compared to patients who ever had an undetectable PSA after radical prostatectomy. For example, cancer-specific survival was 75.5% in the persistent PSA group versus 96% in the group with undetectable PSA. When looking now again at the effect of salvage radiation in these patients, one might think it doesn't have an effect, but when we looked at these patients, we did use propensity score matching between patients with salvage radiation treatment or without. And looking at the whole patient cohort, we do see that patients with persistent PSA and salvage radiation treatment did better, with 93% at 10 years cancer-specific survival versus 82% in the patients with persistent PSA but without salvage radiation treatment. And what I found even more interesting is that when we look at the patients with persistent PSA who had positive lymph nodes after the surgery, we also clearly see the effect of salvage radiation treatment when comparing only lymph node positive patients. Other authors could also confirm that patients with persistently elevated PSA do profit from salvage radiation treatment. This is a study from Fossati and colleagues. But different to our study, they found groups which did not, groups with persistent PSA, which did not profit from salvage radiation. And this was the group with PSA persistence and a Gleason score of 8 or above. However, in our study, we could not confirm this, and we actually found kind of the opposite, that the more aggressive the disease was for the patient, like Gleason 8 or above, or positive lymph nodes or seminal vesicle invasion, these patients did even profit more from the salvage radiation when they had persistent PSA. At last, I want to go over to the salvage radical prostatectomy after radiation failure. So what do the EAU guidelines state on therapy after radiation failure? They mention that therapeutic options in these patients are ADT or local procedures such as salvage radical prostatectomy, cryotherapy, brachytherapy, and HIFU. But they clearly say that strong recommendations regarding the choice of any of these techniques cannot be made as the available evidence is too low. Why should we consider salvage radical prostatectomy at all? It has long follow-up data, it has shown good local control, and it may have the highest efficacy from the local treatment options I mentioned, but it must be weighted against the increased risk of side effects and complications. So in 2012, there was a collaborative review published in European Urology by Chade et al. They included data of more than 1,500 patients who underwent salvage radical prostatectomy. Most of all the series actually were retrospective, and with regards to the oncological outcomes, 5-year BCR-free survival estimates ranged from 47% to 82%. And with regards to the functional outcomes, these data were very heterogeneous in the different studies. The erectile function rates were reported as being 0 to 30%. The urinary continence rates the range was very wide with 21 to 100%, but the reason for this is probably also that there were some series with only 10 or 11 patients, and these were probably very highly selected. What about complications of salvage radical prostatectomy? They are, of course, much higher than in normal radical prostatectomy series. In the ones published, rectal injury, for example, ranges from 0 to 19%, anastomotic strictures from 0 to 33%, and the authors therefore concluded that in selected patients with confirmed localized radiation recurrent prostate cancer, salvage radical prostatectomy may effectively promote durable cancer control with acceptable associated surgical morbidity and variable functional recovery. But how can we identify a good candidate for salvage radical prostatectomy? In general, the EAU guidelines state that salvage radical prostatectomy should be only considered for patients with low comorbidity and a life expectancy of more than 10 years. That is pretty clear. PSA below 10, biopsy Gleason score of 7 or less, and no lymph node involvement prior to the no lymph node involvement at the time of the radiation treatment. We looked at this classification from the EAU. In our patient cohort, 55 patients who underwent salvage radical prostatectomy between 2007 and 2012. And we stratified the patients by these EAU guideline recommendations. And when looking at the oncological outcome, the BCR-free survival after salvage radical prostatectomy, when stratifying them by the concordance with the EAU guideline recommendation, clearly we see that the ones who do fulfill the criteria do much better with 74% versus 11.6% in the other group. And this is also the same for metastasis-free survival. And when looking at functional outcomes, the overall urinary continence rates, we define it as 0 or 1 safety PET, was overall 74%. But very interestingly, when looking at the EAU stratification again, 91% of patients fulfilling the EAU guideline recommendations were continent, while the continence rates in the patients who did not fulfill the criteria was very poor, with 50% only. When looking at the erectile function rates, one has to mention that prior to salvage radical prostatectomy, only 1/3 of the patients were potent, defined as IIEF score of above 18, and only in 8 of the patients a bilateral nerve-sparing procedure could have been performed. So because of these numbers also, it's expected that none of the patients reached an IIEF score above 18 1 year after surgery in our cohort of 55 patients. So what we concluded was that salvage radical prostatectomy is a safe procedure, providing good cancer control and reasonable urinary continence. Oncological outcomes are significantly better in patients who met the EAU guideline criteria recommendations. So we do suggest to use those and to not offer salvage radical prostatectomy to patients who don't fulfill the recommendation. Just recently, the group of Vip Patel published their data on robotic salvage prostatectomy, and they divided the group into a good nerve-sparing group. This was defined as preservation of more than 50% of the neurovascular bundle, and a poor nerve-sparing group, which had less than 50% neurovascular bundle preservation. And in line with all the published data before, overall potency rate at 12 months was poor, with 25.6% in the better nerve-sparing group and 4.3% in the poor nerve-sparing group. So in conclusion, salvage radical prostatectomy has the largest body of data as a salvage option. In well-selected patients, efficacy and morbidity of the procedure is acceptable, but patients must be given a realistic counseling about potential complications and about the alternatives. Thank you.
Thank you, Daria, for this broad overview. Are there questions from the audience? Yeah.
This is a very interesting presentation. I previously worked in Amsterdam, where we also did the salvage lymphadenectomies after PSMA scans, and we even had the availability of iron particle MRI, which, well, some people say is equally sensitive. However, very often you would find additional lymph nodes when you do the extended lymph node dissection. And I remember that only 2 patients I had, which had a single enlarged lymph node, remained PSA-free. So my question is, rather than, like in other cancers, for example, if you have oligo or single metastatic disease, are there data that suggest that there is a biological subgroup that we can cure by salvage lymphadenectomy?
Yeah, so we actually have the same experience. I worked in Munich before, and we published that data that was without radio guidance. And in those patients, all did very poorly. They all had a recurrence after a while. But I showed the comparison. So when using this PSMA radio guidance, we have a feeling that we find the lymph nodes better, and also we are very strict in which patients we include. Ideally, only patients with one PSMA PET positive lesion. There's no long-term follow-up yet, so I cannot really say if it makes sense or not. And the problem is we also don't have randomized data on this topic. So, but I think one shouldn't do this approach if there are more than 2 lesions on the PSMA PET.